So good evening, everyone. I want to welcome you to our first Harvard Divinity School, Harvard Medical School lecture series on religion and medicine. My name is Michael Balboni. I'm a researcher and on faculty at Harvard Medical School and one of the organizers for tonight's event. The vision of this lecture series emerged from a realization of a deep divide between religion on the one hand and medicine on the other, especially as experienced within the university. There's been a lack of engagement on how medicine may be informed by religion and how religion may be informed by the practice of medicine. And the lecture series is an extremely small, but not to be despised attempt to bridge this intersection in order to enable richer conversations to take place at the intersection of religion and medicine, which is why earlier I encouraged you to talk to one another and network with one another and get to know each other, in order to attempt to increase the interdisciplinary dialogue within and across the university, and to create opportunities to build relationships. The lecture series is generously funded by the John Templeton Foundation and will take place one time per semester, at least over the next 3 years. And our guest lecturers will be presenting here at the Divinity School, as well as over a 2-day period of time, giving a grand rounds presentation at one of the Harvard teaching hospitals and giving a lecture to medical students at Harvard Medical School. In April of 2014, the lecture series will welcome Dr. Dan Blazer. He's a leading psychiatry researcher and former chair of psychiatry at Duke, and he's still at Duke. His lectures will focus on the intersection of spirituality, depression, and psychiatry. So we look forward to having Dr. Blazer join us. Tonight we welcome Dr. Dan Sulmasy. He is the Kilbride-Clinton Professor of Medicine and Ethics in the Department of Medicine and the Divinity School at the University of Chicago. He also there serves as Associate Director of the McLean Center for Clinical Medical Ethics. Dr. Sulmasy holds an MD from Cornell and completed his internal medicine residency and chiefship at Johns Hopkins Hospital. And he also completed a PhD in philosophy from Georgetown. He is an internationally known bioethicist, appointed to the Presidential Commission for the Study of Bioethical Issues by President Obama in 2010. He is the author of more than 200 journal articles, including, as I was looking at his CV this afternoon, 160 peer-reviewed scientific articles and more than 40 publications in theology and philosophy. In his free time, he has authored 4 books, The Healer's Calling, Methods in Medical Ethics, now in its 2nd edition, The Rebirth of the Clinic, and A Balm of Gilead. So please welcome me in welcoming Dr. Sulmasy.
What's your sign-up sheet? Yes.
Sign-up sheet. We have sign-up sheets over here. If you want to find out about future events, including next semester's lecture series, please give us your name and email address, and we'll get you that information.
Yes, the sign-up sheets are always important. So thank you, Michael, for the gracious introduction, for the invitation to be here. Thanks to all of you for coming out tonight. I'm going to talk to you about spirituality and healthcare more broadly. I'm not going to talk about anything specific in psychiatry or medicine or anything like that. Let me start with 2 caveats. One is that I will probably occasionally say doctor or medicine. Take this in as broad a way as you can construe it to mean to refer to all healthcare professionals. And second, to say that a fair amount of the language I'll use will be particularly Catholic and Christian. This is not meant to exclude anyone, but just to be sort of particular to my own personal spiritual life in its particular context, and my trust is that it will resonate across people's experiences in other faith traditions or lack thereof. So with that, let me address my question for you, and that's whether health care is in itself a spiritual practice. It might seem like an odd question, that medicine is the most delicate and intricate form of applied science. I think most people would agree. And that what's not science in medicine we might call the art of medicine, making particular judgments about particular patients. I think many people would agree. But to talk about medicine as a spiritual practice, I think most people would say not since the Middle Ages. The era of witchcraft is thankfully behind us. This is the era of molecular medicine. And if anything, chaplains might be of some limited use to some patients, helping them to cope with their illness. But it would be adjunctive. It wouldn't be central to what medicine is. So what has spirituality to do with healthcare or healthcare with spirituality? The answer may first depend on what we mean by spirituality. A lot of people, probably not in this room, in a divinity school, but in other places, equate spirituality and religion. However, even though they're conceptually related, I think we all understand they're not synonymous. In one sense, of course, spirituality is the broader term. I define spirituality simply as the characteristics and qualities of one's relationship with questions of transcendence. In that sense, in its very broad meaning, everyone can be said to have a spirituality. One person may call the transcendent God. One may also live in relationship with transcendence and refuse to personalize or call the transcendent God. And even if one explicitly rejects the existence of the transcendent, one still has a relationship with transcendence, at least by way of rejection. And so even an atheist in this broad sense has a spirituality because that person must search for personal meaning and value in light of his or her rejection of the possibility of a transcendent source of meaning and value. By contrast, a religion is a specific set of beliefs about the transcendent, usually in association with a particular language used to describe spiritual experiences, a community that shares key beliefs, as well as certain practices, rituals, and texts. In that sense, then, religion is narrower than spirituality. Not everybody has a religion. Yet, in another sense, spirituality is also more specific than religion. Because while within every religion there are going to be groups of people who share key beliefs of the religion, remain part of the community of believers, and yet have slightly different ways of praying or slightly different ways of living out their relationships with the transcendent. And ultimately, since every human personality is unique, every human relationship with transcendence will be unique. Spirituality is therefore ultimately personal, because it is only persons who can apprehend, question, and live lives that engage transcendence. Now, I'm already 5 minutes in. You may be asking, what has any of this got to do with healthcare, right? Abraham Heschel, the 20th century Jewish philosopher and theologian, once said in an address to the American Medical Association, attended apparently by 3,000 physicians, that to heal a person, you must first be a person. To heal a person, you must first be a person. To heal, at least in its initial etymology, means to make whole. And I think if we are committed to healing patients as whole persons, what Heschel is probing at is that is pushing us to understand not only what disease and injury do to the bodies of patients, but what disease and injury do to them as embodied persons struggling with transcendent questions. And in the midst of all that's being written and said these days about spirituality and healthcare, to the extent that bookstores actually still exist, I guess there are still a few Barnes and Nobles, right? You can go there and look at the section on spirituality, and there'll be huge sets of books about spirituality and coping with cancer, spirituality and coping with rheumatoid arthritis, spirituality and having prostate cancer, whatever it may be. But it's surprising that so little has been said about the spiritual lives of the healthcare professionals who care for the sick. As Heschel reminds us, if we're to heal patients as whole persons, we ourselves must seriously engage the transcendent questions that only persons can ask. If we're to be true healers, I think it means that we must rediscover what it means for medicine to be a spiritual practice. Now, the relationship between medicine and spirituality became problematic by the late 20th century in a way that it never was in earlier eras or isn't now for many non-Western cultures. And I'll tell you a simple story to illustrate this. It's actually a true story. It's going to sound like a joke, but it's actually true. At least it was told to me by a priest. Maybe he was lying. I don't know. But the story is of a Roman Catholic couple who are attending Easter Mass among First Canadians, at which the native North American bishop is presiding in his native language. All right, you got this? So the couple, and they're both physicians, are the only white people in the church, and the bishop's sermon is lengthy. For Catholics, that means more than 7 minutes. And as he preached, every once in a while he sort of turned to them, sort of acknowledging that he realized they didn't understand a word he was saying. And at the end of his 30-minute sermon, he turns to his guests, acknowledges their presence, and welcomes them in broken English on behalf of the congregation, and then their hearts sink, because he offers to summarize his homily in English. But what he said was this Jesus, strong medicine. Efficacious scientific Western medicine is also strong, but I think the question that many people are asking today is it strong enough? Western medicine works, and very few people want to give up antibiotics or neurosurgery in favor of crystals, but isn't it possible for physicians and other healthcare professionals to practice excellent scientific medicine and still be aware of the spiritual dimension of their work and responsive to the spiritual needs of patients? I hope you'll agree with me that that is still possible. Because particularly if any of you are involved in healthcare or know anyone who's been seriously sick or have been seriously sick yourself, you recognize that illness is a spiritual event. Illness grasps patients by the body and the soul at once and shakes them both. And illness inevitably raises troubling questions of a transcendent nature, questions about meaning, questions about value, and questions about relationship. Those are spiritual questions. How we as healthcare professionals answer these questions for ourselves will affect the way we help our patients struggle with those questions. And I think that in healthcare, we know far too little about the ways in which we touch the lives of our patients, or perhaps in some ways the ways in which we fail them. Recently, for example, I found myself in a discussion with a nurse about the role of touch in relationship to healthcare and spirituality. And I think she had misunderstood something I had said during the lecture, and she came up afterwards to ask me about it. I was sort of defensive, and I said, I really do touch patients. Can I show you what I do? I'm a general internist, right? So I put my right hand on her right shoulder, and then from behind, and then I used my left hand as if it was my stethoscope going back and forth. And those of you who are clinicians know how common and ordinary that is. And I said, I touch patients like this all the time. And she said, "Oh, do you know what that does to people, how it makes them feel?" And I was even more defensive, and I said, "Well, no." And she said, "Well, you could touch people like this." And she sort of leaned on me kind of perfunctorily as if she was doing it for balance. And she said, you could have done that, but here's what you did to me. Do you mind if I show you? And she touched me in this really remarkable way. in a way that felt as if she was touching me and not touching me at the same time, that communicated connection and yet some sense of objectivity at the same time. It felt almost as if there was an electric charge there, but there was no space between her hand and my shoulder. And I said, "Is that what I did to you?" And she said, "I think so. It's what I think you did to me, and probably what you do for all your patients." And at that point, I thought to myself, "Wow, strong medicine, strong medicine." Because from my perspective, the transcendent healing presence of the divine can be found right in the interstices of daily practice, in the infinite space that subsists between our hands as practitioners and the bodies of the patients that we touch. Too few of us bother to reflect on it or to talk to each other about it, but as the poet T.S. Eliot reminds us, we had the experience, but missed the meaning. The transcendent healing presence of the divine is not only to be found in explicitly religious conversation with a couple of patients who are dying, but in all those countless moments in the office or in the hospital in which we communicate meaning and value to our patients and relate to them as whole persons. Now, a drug like adriamycin, which is used in chemotherapy, doesn't necessarily get in the way of that, but it can. If we use the drug incompetently, we betray the trust that the patient has placed in us, a trust that transcends the relationship between patient and practitioner and transcends adriamycin. To betray that trust would be to betray the spirit. But adriamycin can also get in the way of the spirit if we somehow come to believe the falsehood that either the patient's story or our story begins and ends in adriamycin. Right? There are no transcendent pharmaceutical agents, right? But there are always transcendent questions about meaning, about value, and about relationship. And spirituality in practice begins when the clinician becomes aware that these questions arise in and through illness and injury, and that they can be addressed in and through the practice of the healing arts. Paul Ramsey once reminded us that patients are first and foremost persons. I think it's time we began to recognize that physicians, nurses, and psychologists are also first and foremost persons. Now, what we do as healthcare professionals, or at least what we claim to do, is to heal. But we understand too little, I think, about what that means. Healing, etymologically, as I said before, means making whole, but maybe that's too quick. What does this making whole really mean? All too commonly, the understanding of making whole that we find in the literature is quite facile, leading to loose talk about holistic healthcare. And certainly, I can't be opposed to holistic healthcare if it means attentiveness to an ill person's psychosocial and spiritual needs. However, holistic, as you know, sometimes includes the most banal fringes of New Age spirituality. Suggesting almost that, if you eat this spiritual food, you will be better. I believe healing is making whole, but in a very particular way. And the understanding of healing that I want to offer you tonight, and I'm sorry it's after dinner, is going to require us to take a step back from healthcare. I want to suggest that the meaning of healing, in the way I'm presenting it, requires that we understand the constitution of the universe in a way that it might at first seem unfamiliar and strange. Now, a complete explication of what I'm proposing would require a much longer discourse in physics and metaphysics than is possible in a limited number of minutes I have with you. But briefly, the understanding I want to share with you is this, that emerges mostly from particle physics, that the basic stuff of the universe, right, the stuff we call matter, can no longer be conceptualized as what remains after we chop things up into smaller and smaller bits. Chopping is what physics, biology, and medicine did so successfully until the 20th century. breaking up bodies into parts, the parts into organs, the organs into cells, cells into molecules, molecules into atoms, and then ultimately the atoms into subatomic particles. But once you arrive, if you remember studying any of this in college, right? Once you arrive at the particle level, there's a fundamental rule that emerges that's really true about everything, no matter how big or small. And that's this, that field is prior to matter. That what matter is, or anything else is, at its most fundamental level, is not a pile of unimaginably tiny bodies, but a set of dynamic, yet temporary relationships in the electromagnetic field that's already given. Subatomic particles, right, the so-called building blocks of matter itself, can only be understood as entities that are defined as complex relationships. As the physicist Niels Bohr once put it, quote, "In our description of nature, the purpose is only to track down, as far as is possible, relations between the manifold aspects of our experience," unquote. So the naive atomism of Democritus, which was smashed by Aristotle, revived again by Galileo, refined by Dalton, and maybe made normative by J.S. Mill, has been smashed again by Einstein, Planck, Bohr, and Heisenberg. Matter is not isolated bits of individual particularity. Matter is relational. Now, from a philosophical point of view, Bernard Lonergan, the philosopher and theologian Jesuit, has argued that when we know anything, and think of thing broadly, when you know something, whatever that thing is, what you are really grasping is a complex set of relationships. Whether that thing is a quark, a virus, a patient, or a galaxy. In a brief talk, I can't say more, but the take-home message is this: being is relationship. Now, you'd think, for those of us at least who are Christian, that we would have gotten this a long time ago, that we understand the nature of the Trinity to be that God, in God's own self, is relationship. 3 persons in one. But less obviously for physicians. Sickness, rightly understood, is a disturbance in relationships. It's not looking at a bad body inside an otherwise healthy body. As the former editor of the Annals of Internal Medicine, Frank Davidoff, once observed, who has seen a blood sugar? Right? Diabetes is not a bad body inside an otherwise healthy body, but a disturbance in the set of right relationships that constitute the homeostasis of the thing we call a human being. Now, ancient peoples readily understood sickness as a disturbance in relationships. And since these peoples had a keen sense of relationship between human beings and the cosmos, the task of the shaman was to heal by restoring the relationship between the sick person and the cosmos. Thus, healing was primordially a religious act. It constituted the restoration of right relationships between the patient and the gods. Contemporary scientific healing is also about the restoration of right relationship. However, this scientific healing has heretofore understood itself as limited to the restoration of those relationships that constitute merely the homeostasis of the body as an individual organism. From a purely scientific point of view, though, healing means restoring balance in the blood sugar in relationship to insulin and glucagon, and the relationship of the pancreas to the muscle cells and the liver. Restoring someone who's got cancer means making sure that those cells which no longer obey the relationship they ought to have to their neighboring cells gets restored again. Healing somebody who has a disturbance in their heart rhythm means that the atrium, the top of the heart, is now in right relationship electrically and temporally again with the ventricle. Restoring blood pressure to the level that allows the heart and lungs to maintain their proper relationship with other vital organs is what we do when we treat someone who's in shock. So healing is, even in the contemporary sense, restoration of right relationship. But illness, as I have suggested, disturbs more than relationships simply inside the body. It disrupts families and workplaces. It shatters pre-existing methods of coping. It raises serious questions for many patients about their relationships with their God. What medicine seems to be missing today, and I think genuine spirituality can help bring back to it, is this broad understanding of healing as the restoration of right relationships. Not only relationships inside the body, but also between the sick people and their families, their communities, and their God. Now, is the task of doing this, of being a healthcare professional, sufficiently special to warrant calling it a spiritual discipline? Is the practice of healthcare in any way comparable to other religious acts, such as the reading of sacred texts, or fasting, or worship, or prayer? You know, it's tempting at this point to begin to talk about the nature of medicine. However, to talk about the nature or essence of medicine, I think, is philosophically problematic. Medicine is a human practice, but it's not an already out there now real. It's not except in the most Baroque forms of scholastic philosophy, and I don't want to go there. The idea, though, that's typically offered as the alternative to an essentialist view of medicine is a social constructivist view. On this view, medicine is construed merely as a socially constructed enterprise with no fixed boundaries or goals other than what a given society decides it is to be. That view also seems to me to be fundamentally naive. And that's easier to convince physicians of than students in a divinity school. But let me suggest to you that a ruptured appendix followed by sepsis and death is not a social construction. Okay? But a series of objective events to which other human beings somehow feel compelled to respond. The same would be true of almost any other form of illness and injury. Medicine as a social institution is not merely a social construction. I mean, it is a social enterprise, but it's one of the primary responses that a society must make to the objective facts of illness, injury, and death. And the task of human medicine has at least this much objectivity to it, that the subject of the task is a human being. And human beings are a natural kind, distinguished from the rest of reality as particular kinds of things. Human beings are governed by law-like principles that collect together the actual extension of the humankind around an arbitrary good specimen of it. Whether that arbitrary good specimen is Socrates or Michael Balboni, most of you have enough similarities to Michael Balboni to say you're human just like him, right? And there are law-like principles that also determine the characteristic development and typical history of members of the extension of all of us who are collectively called human beings. Medical science is the science of these law-like principles and the study of the characteristic development and typical history of human beings, particularly in their biological dimension. Of course, science doesn't fully explain what it is to be human, but science helps us to understand the biological conditions that are conducive to our flourishing as the kinds of things that we are. And so I take the goal of medicine in a fundamental way to be this: to help our fellow human beings to flourish as the kinds of things that they are, in and through a ministry to the biological aspects of the human. The biological may not be sufficient for our flourishing, but I think you would agree that it's at least an instrumental good in terms of our flourishing. If you die of infantile diarrhea, you will never dance with your daughter at her wedding. Right? If you are cognitively impaired, you will not be able to prove mathematical theorems or become the mayor of your village. If you have a stroke, you may never be able to paint that masterpiece. And if your coronary arteries narrow prematurely, you will never be able to open your heart again in love or in worship. So the kinds of things we are all of us, begins in our status as primate mammals. We are more than that, but we are fundamentally biological beings. And so it is that when I visit the accountant, I can say that my taxes are the issue. When I visit the auto mechanic, I can say that my carburetor is the issue. But in a very real sense, when I visit the doctor, I am the issue. Medicine's subject is fundamentally a common good. What we all have most in common, our biological nature and its finitude. There is no physician who can claim to own medicine. Even a Nobel laureate in medicine has created only an infinitesimally small fraction of the knowledge that he or she can put to the service of the sick. Now, in medical schools, we don't ask those patients who volunteer for our students to practice physical diagnosis, or those who volunteer as subjects in our research projects, or those who donate their bodies for anatomical dissection. Please give us your body at no cost so that we can learn from you and in turn sell it back to your grandchildren at the highest price the market will bear. Right? We ask them to contribute instead to a common good to which we ourselves are pledged, the healing of the sick. The goal of medicine, its telos, in its aim, is to help our fellow human beings to flourish as the kinds of things they are in and through the restoration or preservation or amelioration of human biological dysfunction, the restoration of right relationship in this sense. We help our fellow human beings to flourish as the kinds of things that they are by attending to the biological aspects of their nature. And this goal is so fundamental that it's of more than merits, I think, being considered something special among the tasks that any human being could set for himself or herself. And thus, I think the task of medicine is worthy of being called a spiritual discipline. Society also has a critical interest in having a cadre of physicians who consider themselves called to this kind of work. The basic idea of a vocation carries with it the idea of being called to service. For instance, I'm sure many of you in this room are called to service in the ministry. This is service to a common good. Given a choice between two equally technically competent physicians, one of whom considers the work a calling and the other a job, which are you likely to pick? The sociologists Robert Bellah and William Sullivan have written, in fact, that the notion of a vocation is, quote, the essential element that keeps the idea of a profession from degrading into a merely private career, unquote. The idea of medicine as a spiritual discipline then entails the idea that medicine is somehow an act of faith in something greater than oneself, in something that is at least in that sense transcendent. And this transcendence, that at least transcends you as a practitioner, something you don't own, something that you can't do by yourself, that's bigger than you, is at the heart of what medicine does. And the need that medicine addresses, the need for absolute healing, for absolute restoration of right relationship, is incalculably large and impossible to provide. Medicine is, in the end, a finite craft that addresses an infinite need. The need for healing is infinite. It's infinite. Medicine is also universal in its scientific aspect, and yet it is artfully practiced by and for only particular individuals. Medicine is, on the one hand, an objective enterprise, and yet it is directed towards the service of the subjective experiences of sickness and injury. Medicine is thus intrinsically paradoxical, right? It is finite but infinite, universal yet particular, objective yet subjective. And plunging oneself headfirst into these paradoxes as a physician or nurse must be an act of faith in the mystery of the human. Now, the idea of a call to healthcare as a vocation might seem like a challenging idea in a culture as pluralistic as our own, but I want to argue strenuously that this pluralism need not diminish our sense of calling within the healing professions. We have a common calling even if we acknowledge a variety of callers. The philosopher Alasdair MacIntyre has offered us a way to understand how this is possible through his conception of a practice. And here is how he describes that term. And it's a mouthful if you've ever read it in After Virtue, but I'll read it for you. Right? By a practice, I am going to mean any coherent and complex form of socially established cooperative human activity through which goods internal to that form of activity are realized in the course of trying to achieve those standards of excellence which are appropriate to and partly definitive of that form of activity, with the result that human powers to achieve excellence and human conceptions of the ends and goods involved are systematically extended. That's MacIntyre. Tough to read, right? But if you can follow that enough, it seems that by MacIntyre's definition, medicine is a practice par excellence. We hold the goods and ends of medicine largely in common. Despite our varying beliefs, we understand one human biology. And our aim, the telos of our practice, is that our fellow human beings should flourish as the kinds of things that they are in and through our efforts to restore, preserve, or ameliorate deviations from the law-like principles and typical development and history that characterize them biologically as the kinds of things that they are. Now, the proper use of the adjective good, whenever you use that word, first requires you to understand something about the word that it modifies. With respect to a knife, for example, we have to know something about what a knife is and what it's for before we can say that a particular knife is good. Right? We could then say, once we know what a knife is, then we can say this is a good knife. It's sharp, it's hard, it's got the proper balance, etc. So too with a human practice like medicine. Once we understand what the goal is, what the telos is of medicine, we can then list the characteristics or virtues that make the healthcare professional good. A good physician, for instance, is competent. A good physician is compassionate. A good physician is a lifelong learner, is trustworthy, is neither rash nor indecisive. A good physician is at least modestly altruistic, willing to put the needs of patients before self-interest. A good physician is dedicated to the common good of suffering human beings. Now, there are other virtues we might want to list, but this short number should suffice to establish that we do have in the healthcare professions a common set of virtues. What the famous Dr. Harvey Cushing, the neurosurgeon, once called a common devotion, a common commitment to live lives that are worthy of the oaths that we take. The oaths that we have professed, by these we have declared ourselves willing to respond to a common calling. We may hear that vocational call through a plurality of voices, but I think we do have a common calling. Now, there are multiple barriers that stand in the way of this call to repersonalize healthcare as a spiritual enterprise. The present economic reconstruction of medicine is surely one of those barriers, and those of you who are in the trenches practicing know this, right? Reconceptualized to be like any other industry, the chief virtue in healthcare is no longer, it seems, compassion or empathy or fidelity to patients. The chief virtue seems to be efficiency, just like in industry. Working in a system in which all the parts are considered interchangeable and any patient can see any physician or nurse about any problem at any time or place, it becomes more difficult to believe that questions about relationship have a transcendent meaning. Working in a system in which financial incentives get reconfigured to make the physician and patient economic rivals, it's hard for either the physician or the patient to feel that their value constitutes the dignity of which Immanuel Kant has written, because for Kant, true dignity is that value that has no price and belongs only to persons. And working in a system in which patient visits have been reduced to 7 minutes, it becomes almost unimaginable that questions of meaning could be addressed. And yet these neglected questions of meaning constitute the spiritual in healthcare. So I think the spirituality of medical practice must begin with a frank acknowledgement of how much the people who are in this for the right reasons are suffering today. Many physicians, I think, long to be able to give the spiritual questions of practice their due. But too many find their efforts thwarted by demands to shorten the time they spend with patients, fill out more forms, refer patients to practitioners they don't even know, and treat them with formulary-approved drugs they've never used before, just because they're cheaper. If we're honest, this spiritual suffering of practitioners has two sources, one internal and one external. The internal one is that scientific reductionism has threatened the spiritual aspects of medicine from within by denying the importance of the transcendent. On the outside, the industrialization of medicine now threatens the spiritual from without by denying the importance as well. And yet, particularly for those of you in the room who are in practice, I want to remind you that no amount of economic transformation can alter the fundamental meaning and value of healthcare, nor can it eradicate the interpersonal nature of the healing relationship that begins when one person feels ill and another highly skilled and socially authorized person reaches out with his or her hand and asks, "How can I help you?" Right? That's what I ask. That's what most doctors will ask. "Hello, Mrs. Smith. How can I help you?" The spirituality of medical practice at the dawn of the 21st century is going to demand of us great virtue. Courage, hope, perseverance, and what Marcel called creative fidelity. Now, it's certainly not easy to be a physician or a nurse or a psychologist today. But when all is said and done, those of us who practice the healing arts always will and still do touch our patients in remarkable ways. And the spiritual meaning of medicine is going to outlast every global budget, every attempt to impose the U.S. managed care model on the world, all Medicare cutbacks, all manner of profiteering at the expense of patients. If spirituality is real, it will be real for times of trial as well as for times of triumph. Money can't buy spirituality, and money won't make it go away. So what can healthcare practitioners do to cultivate a sense of the spiritual aspects of medicine in the 21st century that will be helpful to them? First, I would advise any of you who are healthcare practitioners, if you are and you have a religious community to which you believe, to begin to take that as your starting point and take it seriously. Begin to deepen your spiritual life within that religion. I think religion does make it easier for people to grapple with spiritual questions. It gives a person a community of faith and support, a ready-made language with which to describe your spiritual struggles as well as your joys, and practices and texts that can be starting points for a deeper exploration of your own spiritual life. Because patients struggle with the big questions. What's the meaning of my illness? Why must I suffer? Why did my daughter have to die? Is there anything valuable about me now that I'm no longer a productive member of society? Is there anything of value about me that's going to perdure beyond the moment of my death? What is broken in my relationships that I somehow feel called to fix now that my body is broken? Can my doctor possibly understand what I'm going through? A physician or a nurse or a medical social worker who's begun to explore these questions in his or her own life, I think will be better prepared to help patients struggle with these big questions. And I do think one's religion is a good place to start, because genuine religions don't give pat answers to the questions that are so fundamental to the human condition. Physicians who have taken these questions seriously will not trivialize or dismiss the questions of their patients or dispense spiritual bromides to those who struggle with the mysteries of being human in the face of illness and death. Second thing you can do as a practitioner, I think, begin to cultivate specific personal spiritual practices in relationship to medicine, even if you're not explicitly religious, and all the more so if you are. This won't be easy. The physicians in the audience will say, I don't have the time, right? And it's probably not a wise idea also for your neurosurgeon to be having a mystical experience when he's got his thumb in your cerebellum. I'll grant you that. But there are ways to do this, right? Steve McPhee, my colleague at the University of California at San Francisco, says that he just takes 10 seconds in between patients in the office. He just sort of takes a deep breath. He goes from one room to the next, takes a deep breath, and tries to center himself on the notion that the patient he's going to see next is going to be an experience of the sacred for him. That's wonderful if you can do it. I'm too frantic in the office. I can never possibly do that. You may do what I try to do, which is to prayerfully remember your patients at the end of the day. Or again, quoting from Eliot, that if we had the experience, this is a way we can recover the meaning. Even if it rushed by too quickly to notice when it was actually happening. Or perhaps as a practitioner you can start keeping a spiritual journal of what happens in the course of a day. The precise method is not important. As one of my former colleagues in the Franciscan Friars said when there's some Vatican edict saying that there was suspect about Eastern prayer forms, he said, well, I don't know, Dan, if standing on your head makes a person pray better, I'm all for it, right? So whatever it takes for you, try to do it. Third, I think we can find fellow healthcare practitioners with whom to engage these kinds of questions. And maybe daringly for the doctors in the room, expand it beyond doctors. Bring a few psychologists and nurses into the room to talk as well, maybe some chaplains. Because the questions that we have as healthcare practitioners that we don't address for ourselves are really real. What's the meaning of medicine or of nursing? What is its value? What are right and good healing relationships about? Those are spiritual questions. They arise inevitably for believers and non-believers, for all healthcare professionals who take both being a practitioner and being a person very seriously. These are not exactly the questions you find answered or asked in the doctor's dining room, right? But silence constitutes its own conspiracy. I think we can learn from our patients, and we can also learn from each other. How do we deal with our own fallibility? How do we deal with the deaths of our patients? Can we move beyond kvetching about the pressures that we face? Can we see our work as service? Do we ever pray for our patients? Or pray about ourselves as healers? Have we ever experienced the transcendent even once in our work? Can such peak experiences sustain us? Is there any meaning or hope for us? Without talking about these issues, we might begin to doubt the fundamental soundness of our own spiritual struggles. To heal a person, you must first be a person. I think all of us in healthcare are spiritual beings, and healthcare is a spiritual discipline. Thank you.
So we're going to move into our time of question and answers. For those, we have a microphone, so we'd like you to speak into the microphone for the video purposes. We also have, I believe we have some dessert and coffee, so feel free to get that during this time. So let's see, Christine has the microphone, so if you have a question, Christine will bring it to you.
No, that's okay.
I think, again, I should remind people that this microphone is not, does this microphone not amplify their voices? It's just for recording purposes, or? Oh, it does, perfect. Oh, good, does both. Good, okay, great, good.
Be sure to introduce yourself.
Yeah.
Good evening, Professor. My name is Rodolfo. I'm a freelance researcher. I studied medicine, but I didn't finish it. But anyways, I have several questions, actually. One of these things that really bugs me for a while, since the 80s, I studied poverty all over the world, including the US of A. How do we reconcile the 20th century scientific discovery, human government, and laws with the teachings of Buddha, Jesus Christ, Muhammad, and many others?
Okay, I'm sorry.
How do we reconcile
the
scientific discovery of the 20th century,
yeah
human laws and government, with the teachings of Jesus Christ?
I'm sorry, I'm not getting the human
Laws.
Human laws?
And government. LAW.
oh laws.
Yes,
Okay,
forgive my
laws.
accent.
I
have
think I was
several.
hearing laws.
Forgive
okay.
my accent.
Okay.
But anyways, how do we reconcile that?
Well, I mean, this that's a probably several books worth of a question. Again, I don't think that there is ultimately any sense in which if you have a unified theory of truth, that anything that we discover scientifically, refutes any sort of teaching, whether it's dogmatic or theological or ethical, about from any religion, any of the mainstream religions. I can speak, certainly for Christianity, if they're properly understood. Sometimes we have to move beyond, simplistic understandings of religion and beyond simplistic understandings of science in order to be able to reconcile those. But I don't think, in principle, there's anything about, about science, for instance, evolution, etc. I mean, that really can't ultimately be reconciled. So, but it's a huge question, and I'm sorry I can only give you a sort of very general answer to it. So.
Hello, my name is Jutta Hagner. I'm working on a doctoral degree in counseling, and when we have incurable patients, one of the aspects of that condition is that they have a lot of pain. And we may not necessarily be able to put all their relationships internally back together again. In that instance, is pain relief a healing act?
Yes. Well, that's a very good question with two parts to it. Let me first say that that medicine is a finite craft, even if it encompasses the spiritual, and we're not going to be able to always completely, restore all of the interpersonal and spiritual, disharmony in patients, let alone the physical aspects of a patient's healing. The way I've sometimes put this is that dying is never pretty, right? It can be beautiful, but it's never pretty. Right? And sometimes we have a naive view that we can always make it pretty. And patients will often die with their untied endings still untied, right? Including other aspects of their relationships with other people or with God. So we can do the best we can to open a space in which that person can address those questions of meaning, value, and relationship as they're dying. But we should not be so arrogant, I think, as to think that it's ours to correct them, right? It's only to point the way. The second part of the question relates to healing and pain control. Yes, absolutely. I think sometimes, particularly some of my fellow Catholics will say, I want to don't give me morphine. I want to unite my suffering to the suffering of Christ or something like that. And I try to remind them that it's really hard to pray when you're in pain, right? It just sort of takes over your consciousness, and in fact, morphine, when it makes a person who is in pain, whose consciousness has been taken over by that, if you give it in the right dose, gives them enough to be able to actually restore them, which is what usually is the case, then that person can engage in conversation, can engage in decision making, can engage in prayer, and they are in fact restored. And that's why, if you read in the Wisdom of Ben Sira, chapter 38, verses 1 to 15, in the physician's poem there, it says, God made the earth with healing herbs by which the doctor eases pain, right? So I think that that's very much that adequate pain control is very much part of healing for a person, and I don't want to draw too tight a distinction between the physical healing and the spiritual healing that can go on, because they ought to be all done simultaneously and they're interrelated. Yes.
Hi, my name's Kara Curtis. I'm a MDiv student here, but I spent the past couple of years working in a health research context, and so I know firsthand that there can often be a lot of hostility or just not wanting to talk about the spiritual side of things. And I think for reasons that go beyond just that I don't have time for it, I think sometimes it comes out of, negative experiences, even in professional contexts. Like one of the researchers in my center is a reproductive health researcher and, is constantly under threat of being defunded. And so I'm just curious how in your work, you start to just bridge those gaps and just, without being overbearing, just kind of start to invite the conversation.
Yeah, no, it's a great question. Again, I'll start with a little bit of poetry. I shared it with some of the folks this morning from Ezra Pound, a poem that says, "And she is dying piecemeal of a sort of emotional anemia. She wants desperately for someone to speak to her, and is almost afraid that I will commit that indiscretion." Right? That I think that's the state I find. Sometimes it's a state that patients can be in, but more often it's a state that practitioners are in. I mean, they're human beings. They have questions about the meaning of their work, the meaning of their life. They have questions about their relationships. They have questions about their value as persons and whether it all consists in getting the next grant, right? And am I reduced to that? And they know that they're more than that, and often are quite hurting. So I think the easiest ways to do it are, particularly in many of those cases, are with more of a soft sell, right? You just go in and sort of say, how are things? It's the same way I think is what's the best way for those of you who are chaplains know to, talk to a patient or a practitioner to talk with a patient. When I, as a physician, am facing a patient who's got a very difficult time, I sit down and say, how are you doing with this, right? That's all you've got to ask. And I think trying to take the state of the physician scientist as a person, right, and reminding them that they're persons and asking them questions as if you remind them by the question that they are persons is the way to begin. It can be tough because sometimes people have built up such armor around themselves that it's difficult to get in. But I think that's the best way to do it. I wouldn't come in and start preaching or say read the Bible. It's reminding me too of a story from one of my philosophy professors who was Chinese and a convert to Roman Catholicism. She's from Hong Kong, and she said, people came to me and they bring the Bible. They say, you want to be, you read this Bible, you want to be a Christian. She said, I have no interest in reading the Bible. She said, Jesuits come to me, they say, come to party. I went to the party. Then they say, come to another party. Well, I came to another party. And they say, oh, we're having a big party. So I come to the party. The next thing they say, read this book. And the next thing I know, I'm a Christian. So, I think that sort of way of being there. And for me, to be honest, as a clinician, being shoulder to shoulder with people really, really helps. So my fellow physicians will come to me sometimes with questions about, marital problems in the Catholic Church, and sort of, because it's easier to talk to me than it would be to somebody who's wearing a collar, for instance. And so infiltration, soft sell, but being present to people and treating them as persons and inviting is the way to go.
Hi, I'm Paul Kaufman from Australia. I'm interested in psychiatry and religion, and I think already in the first century in Palestine and beyond there was a religious treatment of people with acute psychiatric illness. There was touch, as you were alluding to, and also the Greek language talks about pure spirit driving out impure spirit, but then Paul's talking about men and women, Jew, non-Jew, Gentile, highborn, slaves, all being equal and being a supportive community. So that presumably would help healing someone with an acute psychiatric illness in a religious context, but also the Greek physician Galen, who had wrote at least 30 books. He said if you've got an acute psychiatric illness, you should have a calming environment, exercise 1 hour a day, listen to the harp for 1 hour a day, listen to Greek tragedies and plays, and also make sure your slave massages you for 1 hour a day. Well, how good is that? You know, that must be helpful. That they also had some sort of basic pharmacology, so there was a scientific approach already by the first century as well as a religious approach. In the 1950s, some very interesting American psychiatrists who were also committed Christians tried to integrate their religious faith and beliefs in Christianity with their psychiatric practice. Do you know, apart from Duke University, but do you know anyone around Harvard or Boston who's a practicing psychiatrist and also interested in a research sense in integrating modern psychiatry with religion?
I'd invite people who are here maybe to answer that question. They might know answers to that better. I don't, offhand know anybody. Michael, does anybody come to mind there, or no? Oh, yes, right, that's right, yeah, good.
Associate professor in medical school, Berkeley at Harvard.
Good. Yeah, you'll find wherever you are, there's at least one person. There's somebody in a big university like this who's interested in these questions. And I just would reinforce what you're saying, that we have a lot to learn from people like Galen about, therapeutic communities, right? And so, good.
Just to echo a couple names, I'm Carrie Oxley. I'm a psychiatry resident at Mass General Hospital. And yeah, John Petit has created a wonderful group for Christians who are psychiatrists and psychologists to gather and for conversation. Joanne Angelo is another name that stands out. She's a psychiatrist in the area and a faithful Catholic. And there are a few others, so you can connect with me afterwards.
Good. A community. There you go.
My name is Krish. I'm a MD Psych from India and currently in MD. A question, if I have to look forward into a future, say 10 years from now, what would you see a program, a medical department of psych and spirituality? How did it look like?
Good question. I think that in terms of how it could be structured in healthcare, my best hope, and this is something I shared this morning with the palliative care group and more with the chaplains afterwards, is that the model of hospice and palliative care would be generalized to all of healthcare, right? Where the psychiatrist and the social worker and the nurse and the physician and the chaplain are all part of one healing team, right? And they work with each other and they respect each other and they reinforce each other's work. And I think that may come, because I think that the experiences of alienation from the medical system, which I think patients have been complaining about for several decades, have begun to hit the clinicians as well. That we too, are feeling like just cogs in the machine. The meaning is being drained out from us. We're being pushed in ways that make people want to leave healthcare earlier, which is going to be a terrible problem if we, the Affordable Care Act goes forward. We're going to need lots of primary care doctors, and you can't have them all burning out because the system's demanding too much of them. We need to have a cadre of people who can be, spiritually enriched themselves, who are part of healthcare. And so my sense would be that it's doable within 10 years to move from the hospice and palliative care model of an integrated team, which includes spirituality as a dimension of the care for patients who are dying, to spirituality, which is a dimension of the care for all patients. biopsychosocial spiritual model. What would be the training? The question is, what would be the training requirement for that? Yes, well, it's this I'll borrow from the psychiatrist jokes. How many ethicists does it take to change a light bulb? Just one, but the light bulb has to really want to be changed. A lot of attitude issues that we heard alluded to there are going to need to change. But I think in some ways this is coming from the grassroots. This is coming from the bottom up, this movement. And so I think it's simply going to be that the people who are staunchly resistant to anything, the same people who resisted having ethics in medical schools because it's soft, and didn't like epidemiology because it was soft, are gonna think, but at least at numbers, right? Are going to obviously think that religion and spirituality is soft, and we need to keep that out. But eventually, I think they will become dinosaurs, and there's hunger for this among people, partly because I think practitioners are hitting bottom, just the way, borrowing an AA term, just the way that patients have.
One more question.
Who wants it?
You get it? Okay.
Hi, I'm a student here, a PhD in the religion department, and I'm interested in bioethics. And you talked about healing being, in part, ameliorating divergences from the norm. And I'm wondering if you have any ideas of how we think better about what sorts of divergences from the norm are problematic and should be subject to medicine, and which are workable, and where you think we turn societally for resources for those big sort of worthwhileness questions.
Yes, a very, very, very good question. I mean, medicine is a finite craft, and one of its temptations is to turn, for physicians particularly, to think that MD stands for medical deity, right? And we medicalize everything, right? Everything is our problem. And my mentor, Edmund Pellegrino, wrote about this very presciently in the 1970s, the simultaneous expansion and contraction of the physician's discretionary space, that we were being pushed to be more regulated at the same time that we were having more responsibilities for more and more things. So it's seat belts and nuclear war. They're all part of my responsibility as a physician, and I think that we've got to be more careful about the limits of medicine. And one of the places that this has become very significant for me is in ethics, has been thinking about the practice of palliative sedation and the indications for palliative sedation, where there are people who think, well, the goal of medicine is to relieve suffering, right? And if the patient's suffering is spiritual and existential, medicine ought to still be able to do something about it. And what can medicine do? It can snow people, right? Or it can eliminate the sufferer rather than the suffering, if that's the only way that's left to be able to do it. And I think the problem there is a problem with what I've called a failure to recognize one of the canons of therapy, that we ought to think more about what it means for a physician to recognize the sort of rules that govern therapy. And one of those is the canon of discretion. Right? And part of discretion means recognizing the limits of medicine, recognizing your own limits as a practitioner when you need to refer to somebody else, but also recognizing the limits of the craft. And that there are certain occasions of suffering which I would call neurocognitive, and I would include within those things like delirium or depression, which have a biological basis, which I think can be properly considered part of medicine. But there are other kinds of suffering which are what I call agent narrative forms of suffering. Alienation, loneliness, despair, fear, right? If you look up phenobarbital in the physician's desk reference, it does not say that alienation is an indication for lethal doses of phenobarbital, right? So I think it's more questions about what precisely in that area of recognizing that medicine is a finite craft, recognizing its what it means to be in a therapeutic relationship with someone, what are the meta rules that govern that, and among those are the limits, both for the individual practitioner and for the practice as a whole.